I'm Kevin Gibbons. I'm the Executive Director of UBMD Physicians Group and the Senior Associate Dean for Clinical Affairs here at the Jacobs School of Medicine in Buffalo, New York. I'd like to take this opportunity to give you an update on COVID-19 and our community. This is the third presentation I've given on this line in the last 5 or 6 weeks. The first occurred on November 13th when we saw an alarming uptick in the test positivity rate in our community. And the second was a couple of days before Thanksgiving, as we were very concerned in the healthcare community that we would see a super spreader event in Thanksgiving. Those talks focus mostly on what we need to do, protect ourselves, the concept of staying within your pod or household, and the value of masking. I'd like to take this opportunity to bring you some additional information about the virus and how some things have changed, and how there are additional things that we need to do over the next few months to get through this winter. I'm going to share my slide with you now. So I'm going to review sort of an update on the virus. I'm going to go over the timelines of infectivity. I'll talk a little bit about contagion because that's now an important thing based on some changes that have really occurred in the last 2 days. And I'd like to review again the mortality of this virus and talk about what we need to do to avoid overwhelming the healthcare system so we can take care of you. I'd like to talk about trends in our community and what we've done right. And I'd like to review vaccines, the process and the results of the trials and the importance of getting vaccinated. And finally, I'd like to take a little bit of time to talk about what we can expect in the next 3 months and what we need to do in the next year. So this is actually a slide from an April town hall that UBMD put on for our patients. In it, we describe the unique things about this particular virus. It's a novel virus. It has new antigens. No one has immunity to it. It's highly contagious, and that's the important thing. And it's of moderate virulence, 5 to 10 times deadlier than the flu, particularly in a population without any immunity to it. The strange thing about this virus is that there is a period of time before people get sick with symptoms where they are contagious. That's from the 2 to 6 days after exposure. And there's a large group of patients who have the virus and are shedding it, but they are completely asymptomatic of disease. They don't know they're sick and no one around them knows they're sick. And this can include half of infections in young people. So this is a particularly contagious virus, and that's a big part of the problem we faced in the last year. The timeline for someone with symptomatic COVID-19 illness, if they're exposed at day 0, they start shedding virus in their nasal passages days 2 to 3. They become symptomatic day 4 to 7. Some people get sick early and are hospitalized. Some people can hang out at home for a week before they get really sick. 10% of people, 10 to 20% of people with COVID illness get hospitalized, and 10% of those patients will die. This is a concept I'd like to spend a little bit of time on. It's the idea of contagion. We heard about R factors in the spring. An R factor is the number of infections that come from a person with an infection. Or if you have trouble figuring out how a 0.9 person, if you have 100 people have an infection now, how many people do they infect next week? Is it 200? Is it 80? Does the disease go up or does the disease go down? The R naught is the number of infections with a novel virus in a population with no prior exposure, no vaccine, no measures to decrease it. With measles, that number is very high. It's 18. One person infects another 18. That's why it's so important for all our kids to be immunized to protect the child with cancer or the pregnant teacher in school. The RT is the actual rate of transmission in the community, and it includes the factors of varying degrees of immunity and efforts to control the disease. The R naught for COVID is between probably 2 and 4. The RT for COVID depends. We were actually below 1, meaning the amount of disease in our communities was decreasing over the summer. Then we were up above 1, but generally we haven't gone above 1.4. Yesterday, the European branch of the World Health Organization, essentially the CDC for Europe, announced the identification of a new variant in southern England with an RT of at least 1.5. That's important because the higher the RT goes, the more people have to get vaccinated to achieve herd immunity. So that information makes vaccines even more important. It doesn't appear that this new variant is more deadly. It's just more contagious, and that presents a problem. The mortality rates for this disease is pretty well established. The older you are, the worse it gets. People around 60, my age group, 1 out of every 100 who get it die. The older you get, that number goes up. The mortality rate overall is between 0.5% to 1.4%. The mortality rate in skilled nursing facilities is obviously greater. 6% of cases result in 40% of deaths from nursing homes. So isn't this just a disease of the infirm and the elderly? Well, we knew early on that those were the most affected, but we early on also identified that there was a serious pediatric multi-system inflammatory disease. We knew that people who get this disease can have, quote, long haul symptoms. That's often shortness of breath and fatigue and brain fog. 20% of people at 4 weeks, 10% of people at 3 months can still have significant symptoms. We do know that there are fatalities among the young and otherwise healthy. This is a picture of Adeline Fagan. She was a medical school graduate from our medical school in 2019, doing an OBGYN residency in Houston, who died of COVID-19 this September. I mentioned earlier that 10% of people who are in the hospital die. That means 90% survive. But it requires a fair amount of work. It requires high flow oxygen therapy and critical care in many patients. Those resources are limited. You may recall these graphs from earlier in the year. The one on the upper left talks about unchecked disease in a community without protective effect. That blue circle is the area above the dotted line. That's where the healthcare system gets overwhelmed. The graph in the upper right is a mitigation strategy. That's where we attempt to delay the disease, although we don't decrease necessarily the total number of people who get it, but we avoid overwhelming the healthcare system. And then the suppression concept in the lower right-hand corner, where with proper measures, mostly masking and social distancing, we decrease the number of patients who get the disease, and we delay it, and we avoid overwhelming the healthcare system. It's important to note that overwhelming the healthcare system is a real concern. In Erie County, we have less than 300 ICU beds. We have over 900,000 people in Erie County. Imagine if you had a situation where you had 900,000 people all wanting a seat in the 72,000 seat Bills Stadium. It's impossible to do. We understand a little bit about supply and demand. Look what happens when every household in Western New York decides they need a 4-month supply of toilet paper. This is a graph that's been seen before. This shows the yellow line, which is the rolling 7-day average of positive tests. It showed we were around 2 during the summer, but late in the fall, it started to shoot up. The red line are hospital admissions. Those always are delayed behind the elevation in test positivity, generally by a week or a little bit more. The first vertical blue line is the November 13th talk I gave. That week, the test positivity rate was shooting up, and we had a single day test positivity the day before that of 8.4%. The second blue line is the talk I gave a couple of days before Thanksgiving. That's when we were very concerned that Thanksgiving was going to be the super spreader event of 2020. The good news is we saw a bump afterwards, but we did not see a major spike or acceleration. But we have seen more deaths from COVID in December than any other month of this epidemic, and we still have another week to go. In one of my previous talks, I mentioned with glee that vaccines work, and my colleagues were quick to correct me to point out vaccines only work if they're taken. That means vaccinations work. We need enough people vaccinated so that we develop herd immunity in our community. Herd immunity is the goal. It's not the strategy. We want people to become immune through vaccination. People who get the disease and survive, we assume are immune for a while. We don't know how long. Everyone needs to get vaccinated. We have 2 vaccines now currently approved through an emergency use authorization. This week, 8 million vaccines were delivered in the United States. People ask me if I'm getting a vaccine, and I have gotten it, and I encourage everyone to do the same. These trials, these two very large trials, 44,000 in one trial, 30,000 in other, were the gold standard randomized double-blind placebo-controlled trials. And it proved these vaccines are 95% effective at preventing symptomatic disease and very effective at preventing severe disease and death. And it includes the usual side effects, the most common being a sore shoulder, which I had for a whole 4 or 5 hours. Those vaccine trials, 75,000, 74,000 people. Now that we're using it, giving it to millions, we've discovered that patients with a history of anaphylaxis can get an anaphylactic reaction. That's a severe allergic reaction to this vaccine. These are individuals who carry EpiPens because they have a history of anaphylaxis and they responded well. No one has been seriously harmed by this reaction subsequent to the vaccine rollout. It needs to be followed. The typical vaccine development is a 10 to 12-year process. There's an idea, then there's synthesis, then there's a phase 1 trial and analysis of results, discussions with the FDA, phase 2 trial, analysis, discussions, phase 3, further analysis, submission for approval, eventual approval, decision made to scale up and make millions of doses and then distribute them. What COVID has done has compressed the process without cutting the corners regarding safety. We knew the genetic sequence in January, the vaccines were designed in March, phase 1 and 2 occurred in the second quarter, phase 3 started in July, in November the results were released, and in December they were approved and sent out. So the typical vaccine production is a series of events with pauses between each event. What we've done this time is we've done multiple things in parallel or simultaneously, ready to deliver should the results show that this vaccine's work. Millions of doses were made in advance of approval, realizing that if the trial had failed, they'd get flushed down the toilet, so to speak. It's important for people to get vaccinated when they're called to do so. This community needs as many people vaccinated as possible. I'd like to mention or review what the near future holds. There is rapid vaccine rollout in this community. First, in terms of high-risk populations, high risk in terms of who is exposed to the disease, that being healthcare workers, and the next line, other essential workers, grocery store clerks, et cetera. And those who are high risk because of risk of dying from this disease, nursing home populations. Those people are being vaccinated as we speak. Next, other groups will follow very quickly. We still need to mask for the next 3 to 4 months when we are outside our immediate household. We need to limit the number of people we share our germs with. That means you have to mask when you are with others outside your immediate household or pod, especially when you're indoors. The good news is that spring will come, weather will get better, we will be outdoors again, that will help. And over the course of the summer, there will be additional vaccines coming down the road, different types of vaccines, and maybe better for different populations, a vaccine that works in young children or adolescents. We're going to find those and we're going to get those out. So we have another few months to get through this. We have to make sure it's not the darkest winter in history. We also have to realize what a brutal year this has been. People have lost loved ones. People have lost their jobs. Some people who've been employed have been working incredible numbers every week, dealing with people who are suffering and dying. Business owners have seen incredible losses of their business and their livelihoods. Children have lost incredible amount of time in terms of their emotional and intellectual development by being out of school. The kids on the margin are suffering terribly. We need to pay attention to these things in the next year as we attempt to recover from what's been a terrible 2020. So thank you for listening. For the next few months, everyone needs to mask up. Everyone needs to get their shot when it's their time to get their shot. We need to work hard, but we have reasonable hope, and we should hope and pray 2021 will be a much better year. Thank you.